Having a ball cage mitral prosthesis for 5 years, this patient has remained in sinus rhythm. By CW Doppler, the early velocity peak is 1.5 meters per second, and the atrial velocity peak is 1.8 meters per second. The end diastolic velocity at the closing click is much lower, 0.3 meters per second, indicating no end diastolic gradient. The velocity spectrum has been traced, and the resultant mean gradient is 4 millimeters of mercury. The deceleration slope has been traced, yielding a pressure half-time of 136 milliseconds, which equates with a mitral valve area of 1.6 square centimeters. All of the prosthetic valve hemodynamics that we have mentioned for both aortic and mitral valves can be measured not only at rest, but also with exercise. CW Doppler can be performed during supine or upright bicycle exercise or immediately after treadmill exercise. This is a continuous wave examination from the same patient with the Starr-Edwards mitral prosthesis. Supine bicycle exercise was used, and the heart rate increased from 62 to 90 per minute. In real time, you will notice that spectra are intermittently lost due to increased respiration. Note that early and atrial velocities have only slightly increased with exercise, but there has been a significant reduction in the diastolic flow period, so that the mean gradient has increased from the resting value of 4 to 7 millimeters of mercury. With exercise, the pressure half-time has decreased from 136 milliseconds to 121 milliseconds, which correlates with a slight increase in the calculated mitral valve area from 1.6 to 1.8 square centimeters. This slight increase in effective orifice area is expected with the increased cardiac output during exercise. Recent studies have raised concern that the pressure half-time method overestimates the true effective orifice area for mitral prostheses. You should be prepared to calculate the effective orifice area by an alternative method, particularly when you find a mean mitral gradient that is higher than you would expect for the pressure half-time valve area. For patients without aortic regurgitation, the continuity equation can be applied to mitral prostheses in a manner very similar to that which we described for aortic prostheses. The diameter of the left ventricular outflow tract is measured from a systolic freeze frame and converted to LVOT area as we previously discussed. From apical long axis, the velocity spectrum from the LVOT is recorded by placing a PW sample volume just below the aortic valve. Using the continuous wave mode, we record the velocity spectrum from flow across the mitral prosthesis. From the continuity equation, the mitral prosthesis effective orifice area is equal to the LVOT area times the LVOT time velocity integral divided by the mitral TVI. Note that in this case, the LVOT TVI must be used. One does not have the option of simply using the peak LVOT velocity. This patient has Starr-Edwards tricuspid and mitral prostheses. Here, the non-imaging transducer has been angulated toward the tricuspid prosthesis. These signals can be distinguished from mitral signals by the characteristic respiratory variation. You'll recall that the tracing from the nasal respirometer rises with inspiration and falls with expiration. Compared to expiration, inspiratory cycles show an increase in early peak velocity as well as an obvious increase in mean gradient. These signals are from the mitral prosthesis. While there is a slight variation with cycle length, there is no increase in the velocity spectrum with inspiration. Now that we have discussed normal Doppler hemodynamics for prosthetic valves, we must emphasize the importance of obtaining baseline studies for future comparison. Following implantation of a prosthetic valve, it is mandatory that a routine echocardiographic study should be obtained upon hospital dismissal or within the first 1 to 2 months post-op. Having discussed imaging and Doppler hemodynamics for normal prostheses, we will now turn our attention to the echocardiographic identification of prosthetic valve pathology. We will begin with a discussion of pathologic prosthetic valve stenosis. Thrombosis and pannus formation are the two most common causes for pathologic stenosis of mechanical prostheses. Bioprostheses most often become stenotic because of cusp degeneration and calcification. This patient presented with increasing dyspnea and cough 9 years after implantation of a 21 millimeter Bjork-Schiley aortic prosthesis. By echo, we discovered that she had moderate mitral stenosis and severe tricuspid regurgitation. At the same time, we noted dense echoes in the region of the aortic prosthesis. In real time, you will notice that motion of the reverberations within the aorta seem reduced. The maximum Doppler velocity spectrum was obtained with a transducer in the apical position. The maximum velocity across the aortic prosthesis was 5.1 meters per second, and the mean gradient was 56 millimeters of mercury, both of which are significantly increased for a 21 millimeter Bjork-Schiley prosthesis. At surgery, pannus ingrowth on the undersurface was found to significantly obstruct the prosthesis. This patient presented to us 4 months after implantation of Omniscience mitral and aortic prostheses. The Omniscience valve is another type of tilting disc prosthesis. This patient had developed orthopnea and her chest x-ray showed pulmonary edema. Her aortic prosthesis had normal hemodynamics by Doppler. In this apex up 4-chamber view, you see the usual reverberations from the mitral disc in the left atrium. In real time, you will see that the disc motion appears reduced. Color flow imaging also suggested stenosis of the mitral prosthesis because the diastolic jet was narrow at its origin and quite eccentric. Using a duplex CW transducer, the mitral diastolic velocity profile was recorded with an early peak of 2.7 meters per second. The mean gradient was increased at 20 millimeters of mercury, and the pressure half-time was markedly prolonged, 250 milliseconds. Transesophageal echocardiography was performed. With the transducer behind the left atrium, the disc reverberations appear in the left ventricle. In this diastolic frame, the opening excursion of the disc is significantly reduced. The reduced opening angle of the Omniscience prosthesis is even more evident when it is compared to the normal opening angle of this Bjork-Scheile mitral prosthesis. At surgery, the Omniscience valve was found to have a large thrombus, which was inhibiting disc opening. Patients with prosthetic valves can manifest subaortic obstruction, which can be diagnosed by echocardiography. For aortic prostheses, the subvalvular stenosis is dynamic due to left ventricular hypertrophy that developed before implantation of the prosthesis. Mitral prostheses can actually cause LVOT obstruction. Patients with valvular aortic stenosis can develop asymmetric hypertrophy, resulting in a Venturi effect with dynamic subvalvular obstruction. This dynamic obstruction will persist after aortic valve replacement unless a myotomy-myectomy is also performed. This patient was studied while recovering from implantation of a bioprosthetic aortic valve. The septum is hypertrophied, and there is systolic anterior mitral motion. The CW exam demonstrates a late peaking systolic profile typical of dynamic LVOT obstruction. The maximum velocity is 4 meters per second, which means that despite the aortic prosthesis, this patient still has a maximum instantaneous gradient of 64 millimeters of mercury across the LV outflow tract. This patient has a tilting disc mitral prosthesis. Her native aortic valve is normal, but notice how the mitral sewing ring narrows the LVOT. The maximum velocity across the LVOT was 4.8 meters per second, with a mean gradient of 51 millimeters of mercury. This lesion should always be included in the differential diagnosis of a systolic murmur that is heard soon after mitral valve replacement. We will now discuss prosthetic valve regurgitation, beginning with aortic prostheses. Prosthetic valve regurgitation can be transvalvular, perivalvular, or a combination of both. For bioprostheses, transvalvular regurgitation most commonly results from cusp degeneration. For mechanical prostheses, transvalvular regurgitation most commonly results from thrombus or pannus ingrowth. Regurgitation can also be caused by change in the shape of the poppet or disc, which is referred to as poppet or disc variance. Aortic prosthetic regurgitation can usually be fully assessed by surface echocardiography. The jet is directly below a transducer placed in the left peristernal position, and it comes directly toward a transducer in the apical position. From these positions, the sound beam can interrogate the jet without having to cross the prosthesis. As with native aortic regurgitation, complete assessment of the regurgitant aortic prosthesis requires an integrated approach. Color flow imaging allows us to assess the extent of the jet relative to the left ventricular outflow tract. The color flow exam is supplemented by continuous wave Doppler. We pay attention to the signal strength of the regurgitation, and we use CW to measure the aortic regurgitation pressure half-time. By pulsed wave Doppler, we assess the amount of reversal in the descending aorta. And we also check for reduction in the mitral pressure half-time and for diastolic mitral regurgitation. 2D and M mode are used to assess the functional significance of the regurgitation via analysis of LV size and function. This patient has Starr-Edwards mitral and aortic prostheses, which appear normal by the 2D exam. A regurgitant jet can be identified originating from the aortic prosthesis. However, it is difficult to be certain about the jet dimensions because it merges with the diastolic jet from the mitral prosthesis. The spatial extent of the color jet is best appreciated from the parasternal short axis view. This is the left atrium, and this is the left ventricular outflow tract, just below the level of the aortic sewing ring. The aortic regurgitation jet area is small compared to the LVOT area. This patient has Bjork-Scheele aortic and mitral prostheses. This is a remnant of the mitral support apparatus. The mitral and aortic discs open and close normally. This is an expanded parasternal long axis view of the mitral and the aortic disc prostheses. This is the LVOT. A small color jet of periprosthetic aortic regurgitation arises from the anterior portion of the sewing ring. In parasternal short axis format, we can appreciate that the aortic regurgitant jet actually occupies nearly 1/2 of the circumference of the sewing ring. We felt that this was moderate regurgitation, but it is difficult to be confident with this unusual jet shape. The CW envelope of aortic regurgitation was easily obtained and fully defined, although the regurgitant signals are less intense than the forward flow signals. The pressure half-time of aortic regurgitation was 486 milliseconds, which is also consistent with the assessment of moderate regurgitation. This patient had a mitral annuloplasty and implantation of a heterographed aortic prosthesis. These are the stents. The valve had degenerated. This cusp is torn, and it is prolapsing into the left ventricular outflow tract. In systole, mitral regurgitation fills the left atrium, and a broad jet of aortic regurgitation fills the LVOT in diastole. An M-mode cursor has been placed across the LVOT and the left atrium. The color M mode shows aortic regurgitation filling the LVOT and diastole, and mitral regurgitation filling the left atrium in systole. This is a parasternal short axis view in diastole. Color signals in the left atrium are from pulmonary venous inflow. The aortic regurgitant jet completely fills the LV outflow tract. This patient has a ball cage aortic prosthesis. This is the cage within his enlarged aortic root. The prosthesis rocks freely, indicating a large dehiscence. This is the aortic prosthesis. The sewing ring has separated from the aortic annulus, which is here. The prosthesis has rocked into the LVOT. This will be more apparent in real time. While we suspect that aortic regurgitation is severe, it is difficult to precisely define the color jet because of the rocking mechanical prosthesis. This is the descending aorta imaged from the suprasternal notch. In this diastolic frame, reversed flow fills the aorta, confirming the severe degree of prosthetic aortic regurgitation. A sample volume has been placed in the descending aorta. The diastolic reversal is high velocity, 0.5 meters per second, and persists throughout diastole, again supporting a diagnosis of severe aortic regurgitation. As final confirmation, the severe aortic regurgitant jet has a pressure half-time of only 222 milliseconds. This case clearly illustrates how 2D, color flow, PW, and CW exams are combined to arrive at an accurate assessment of the severity of prosthetic aortic regurgitation.